Hi guys, I'm Raven Capolan, a student nurse from Western Sydney University, and this is my ID card. And today, I'm going to discuss a case study for my Health Variations 3 oral presentation. So I'll give you a brief background about our case study today. So our patient's name is Mrs. Teresita Manalo. She's a 65-year-old female patient who experienced an acute embolic stroke during her hospital admission. Initially admitted with symptoms of dizziness, palpitations, and general malaise, she was diagnosed with atrial fibrillation and commenced on heparin therapy under cardiology care. She was being prepared for discharge when she was found during a night shift ward round with a decreased level of consciousness, slurred speech, and new onset of left-sided weakness. So we'll proceed with question number 1, which focuses on the A to E assessment approach to Mrs. Teresita Manalo, integrating her vital signs to guide clinical decisions in the context of an embolic stroke. So we'll proceed with the airway. Her airway is patent. Although his speech is slurred, she is able to speak and respond to verbal stimuli. These observations confirm that her airway remains open. An indication of a patent airway is the patient's ability to speak with a usual voice, full sentences, according to nursing times. No signs of obstruction have been noted in the assessment. However, due to her decreased level of consciousness, close monitoring of her airway is important, as stroke patients with impaired consciousness may lose their protective airway reflexes, according to Considine and Anderson 2024. As a nurse, placing her in a semi to high Fowler's position can help prevent aspiration and maintain a clear airway, according to Barton and Johnson 2023. So we'll proceed with breathing. So her breathing is shallow and her respiratory rate is 26 breaths per minute, indicating tachypnea. This could indicate neurological dysfunction or a compensatory mechanism in response to decreased oxygen levels after her embolic stroke. Her oxygen saturation is currently at 95% on 6 liters Hudson mass, which is suitable for providing moderate oxygen support. Oxygen therapy plays a vital role in maintaining sufficient oxygen levels, particularly in individuals with neurological conditions, since the brain is extremely vulnerable to hypoxia, according to Barton and Johnson 2023. The aim is to maintain the oxygen saturation at or above 95% to prevent further neurological deterioration, according to Barton and Johnson. So, if her oxygen saturation falls below the borderline, it may be necessary to increase oxygen delivery or initiate additional respiratory support. Now we're moving on to her circulation. So her heart rate is 132 beats per minute, indicating tachycardia, which aligns with her atrial fibrillation. Her blood pressure is elevated at 170/95, indicating hypertension that requires close monitoring. So according to Jiang et al., in the context of acute stroke, elevated blood pressure may help maintain cerebral perfusion, but excessively high levels increase the risk of complications such as hemorrhagic transformation. The vital signs support urgent interventions such as continuous cardiac monitoring, blood pressure control, as well as escalation if the patient condition worsens. And now we're moving on to disability. For the disability assessment, her Glasgow Coma scale is 12 out of 15 with eye opening to voice, a verbal score of 3, and a motor score of 5. She presents with slurred speech, left-sided weakness, and facial droop, which are consistent to her diagnosis of embolic stroke. Despite this, she can follow commands using her unaffected right side. Her pupils are equal and reactive to light, and these findings indicate neurological impairment. Barton and Johnson stated a decline in consciousness and the emergence of new neurological symptoms requires urgent review and escalation to ensure timely interventions and prevent further deterioration. For the exposure assessment, Mrs. Manalo is afebrile and there is no visible wounds or bleeding. An intravenous cannula is intact and placed in her left cubital fossa, delivering compound sodium lactate at 20 ml per hour to maintain vein patency. Considine and Anderson stated that these findings suggest peripheral access is secure with no current signs of infection or injury. Keeping the IV line in place allows prompt administration of medications or fluids if her condition deteriorates. Now I'm going to discuss 4 high-priority nursing interventions I need to consider when caring for Mrs. Manalo's embolic stroke, including, first one, maintaining airway patency and optimal oxygenation. Second one, minimizing risks related to mobility and aspiration. Third one is conducting continuous neurological assessment. And last one is managing circulatory function and preventing further thromboembolic events. So for the first one, it is important to continue monitoring Mrs. Manalo's airway patency, respiratory rate, oxygen saturation, and level of consciousness while maintaining supplemental oxygen via Hudson mask at 6 liters. Her reduced level of consciousness combined with left-sided facial weakness increases her risk of airway obstruction and risk of aspiration. So as a nurse, positioning her in a semi to high Fowler's position helps promote ventilation and reduce the risk of aspiration. Ongoing monitoring enables early detection of respiratory issues while maintaining adequate oxygenation, supports cerebral perfusion, and helps prevent secondary hypoxic brain damage. For the second priority, repositioning Mrs. Manalo every 2 hours, supporting her affected left side with pillows, and conducting the man's assessment of swallowing ability prior to initiating oral intake are important interventions that help prevent complications associated with immobility and neurological impairment. Regular repositioning and providing a proper support enhance circulation, prevent pressure injuries, and maintain proper body alignment. Using the man's assessment of swallowing ability prior to oral intake helps reduce the risk of aspiration and aspiration pneumonia in patients with swallowing difficulties. These interventions contribute to improved comfort, patient safety, and support the overall recovery process after an embolic stroke. For the third priority, conduct regular neurological assessments, including evaluation of her GCS, Pearl, limb strength, and speech. and promptly document any signs of deterioration. Any drop in GCS by 2 or more points or the emergence of new neurological symptoms should be immediately reported to the Rapid Response or Stroke team. According to Gully, ongoing neurological monitoring is crucial for identifying stroke progression, hemorrhagic changes, or rising intracranial pressure early, enabling early intervention and escalation of care. Timely detection of neurological decline is essential for initiating treatments such as thrombolytic or neuroprotective therapy, which can significantly enhance patient outcomes. So for the fourth priority, it is essential to consistently monitor Mrs. Manelo's vital signs, including her blood pressure, heart rate, and cardiac rhythm, while continuing her prescribed heparin infusion and routinely evaluating her coagulation parameters, including prothrombin time or PT, International Normalized Ratio, INR, and activated partial thromboplastin time or APTT, to ensure therapeutic anticoagulation is maintained, reducing the risk of recurrent embolic stroke while minimizing the potential for bleeding complications. Additionally, it is important to maintain the patency of her intravenous access for the rapid administration of emergency medications or fluids if needed. Uncontrolled atrial fibrillation and hypertension significantly elevate the risk of recurrent embolic events and intracerebral hemorrhage. Therefore, maintaining therapeutic anticoagulation while monitoring for bleeding is important to ensure stroke prevention while ensuring patient safety, according to Verona et al. 2020. Keeping hemodynamic parameters stable further promotes effective cerebral perfusion without increasing intracranial pressure, according to Gagauzova et al. 2025. So for question 3, I chose 3 medications. I chose the first one is IV alteplase, second one is heparin IV infusion, and third one is metoprolol. So before administering IV alteplase to Mrs. Manelo, I, as a nurse, must verify that she qualifies for thrombolytic therapy criteria and has no contraindications such as recent surgery or active bleeding. Given her history of atrial fibrillation and current heparin infusion, it is essential to review coagulation tests including PT, APTT, and INR prior to administering the medication, according to Southeastern Sydney Local Health District 2025. The medication is administered through an IV with 10% of the total dose delivered as a bolus over 1 minute, followed by the remaining 90% infusion over the next 60 minutes. The nurse must confirm that the 2 large bore IV cannulas are inserted and that the emergency equipment is readily available and functioning at the bedside. Throughout administration, close monitoring of neurological status, blood pressure, cardiac rhythm, and oxygen saturation is essential, as serious complications like intracranial hemorrhage or angioedema may arise. Following administration, the nurse must enforce strict bed rest for 24 hours, closely monitor for any signs of bleeding, and avoid invasive procedures such as intramuscular injections or catheter insertions unless absolutely necessary. So alteplase is a single-use therapy not intended for daily dosing and should not be administered with food. The nurse must verify any known allergies to alteplase or its component, including gentamicin, and ensure all observations and interventions are thoroughly documented in the patient's health record. So the second medication is heparin IV infusion. Mrs. Manelo has been prescribed heparin as part of her anticoagulant therapy, administered through IV infusion to maintain catheter patency or support dialysis treatment, according to MINS Australia. IV administration is essential to ensure rapid and controlled action, as other routes are ineffective for this purpose. Before starting her therapy, the nurse needs to check her baseline platelet count, coagulation profile, including her APTT, PT, and INR, as well as her renal function and electrolyte levels, with close attention to potassium because of the risk of hyperkalemia. The nurse should also review her allergy history, focusing on any sensitivity to porcine derivatives or previous cases of heparin-induced thrombocytopenia, which would make heparin unsuitable for use. While administering heparin, the nurse should set the infusion pump accurately and prepare the IV line to avoid clot formation. Teresita's coagulation levels, especially APTT, should be monitored every 4 to 6 hours initially until stable, according to MIMS Australia. The nurse should check for bleeding signs such as bruising, hematuria, gastrointestinal bleeding, or neurological changes, and inspect the IV site for redness, swelling, or tissue damage. Those adjustments may be necessary if Teresita has risk factors such as advanced age, chronic kidney disease, or smoking history, as this can affect her sensitivity to heparin. After heparin administration, the nurse should continue monitoring her coagulation profile and remain alert to delayed onset heparin-induced thrombocytopenia or HIT, which may appear days after exposure. Any adverse effects must be promptly documented and reported. Since food does not affect IV heparin, no dietary changes are needed. However, the nurse must carefully check for drug interactions, especially with non-steroidal anti-inflammatory drugs, antiplatelets, corticosteroids, and other bleeding risk medications by thoroughly reviewing her medication chart. The third medication is metoprolol. Upon admission, Mrs. Manelo underwent a 12-lead electrocardiogram or ECG, which revealed her atrial fibrillation. Subsequently, she developed an embolic stroke. According to the Australian Medicine's Handbook, metoprolol is a cardioselective beta blocker that can be administered to manage her rapid heart rate of 132 beats per minute and elevated blood pressure of 170/95, which is hypertension. Before administration, nurses must assess her heart rate and rhythm. Although her current heart rate is 132 beats per minute, caution is necessary if bradycardia below 50 beats per minute, atrioventricular ventricular block or hypotension occurs. Metoprolol should not be used in cases of uncontrolled heart failure, and Mrs. Manalo is exhibiting signs of fluid overload such as beating edema and cold extremities. Therefore, careful monitoring of her cardiac condition is important. During administration, monitor her for signs such as dizziness, fatigue, or any indication of deteriorating heart failure. Given Mrs. Manalo's blood glucose level of 5.5 millimole per liter, regular glucose monitoring is essential as metoprolol can mask hypoglycemia symptoms and should be taken orally twice a day with or without food. Additionally, metoprolol should not be suddenly discontinued to avoid rebound hypertension or arrhythmias. Mrs. Manalo's respiratory rate of 26 breaths per minute and shallow breathing used with caution if she has asthma or COPD, though beta-1 selected agents like metoprolol are generally safer according to Australian Medicine's Handbook. So that's it for my Health Variations 3 oral presentation. I hope you guys have a good day. Thank you.